Good afternoon. My name's Troy Pennington. I've had the opportunity to meet several of you. I'm from Region 2. I work at a hospital called Arrowhead, which is in Southern California. It's a little bit of a misnomer. People picture a beautiful, peaceful place, perhaps something like Vail. We're the San Bernardino County Hospital. We're the Regional Trauma and Burn Center. We're a busy place. We see about 140,000 patient visits a year through our ED. We have been using TXA in our emergency department for the past year and a half. And I know that a couple of you out there are actually already using it. And I wanted to try to bring up a discussion and kind of, as Dan was doing earlier, try to build a consensus on where everybody's at with the use of TXA. I'm going to go through a little bit of the literature, some of the studies that are out there. And then after we go through some of that, then I'd like to try to hold a discussion and try to get your input and see where everybody's at with TXA administration. I'm by no means an expert. I've had about a year and a half of experience with TXA in our emergency department, but our outcomes have been favorable, but our numbers are still pretty small at this point. The little video that's kind of running in the background that's quiet is about to show you a couple of pictures. This was actually a video that was made, the CRASH 2 study, which we're going to spend some time talking about. They actually went and they met with actually one of the inventors of tranexamic acid. It was actually invented by a husband and wife team back in the late 1950s. I don't know if she's come on to the screen yet. She's about to right now. My Japanese is terrible. Her name was Utako Ukamoto, I think was her name. I think she's still alive to this day. When they interviewed her, she was 93 years old. And that actually is the inventor of tranexamic acid. It's been around for a long time. I was quite surprised to find this out when we first started using TXA. I thought it was rather new because I hadn't had a pharmaceutical rep putting it in front of me. But it's been available in the UK over the counter for the treatment of menorrhagia since 2011. It's been available over the counter in Sweden for the treatment of heavy menstrual bleeding for the past decade. So it's not a new drug. It's been around for a long time. There are quite a fair amount of studies on the use of TXA. I'm not going to torture you with all of the intrinsic and extrinsic pathway. There's not going to be a quiz at the end, but I do think that I need to kind of go back over some of the basics to review the mechanism on how TXA works. The three primary steps for hemostasis are vascular spasm, platelet plug, and coagulation. And you can see in the little video here that you had a little nick in the vessel wall. Factors are exposed that are not normally there, primarily collagen. Collagen stimulates this clotting cascade. Essentially what happens is the platelets become activated. I think of them kind of going into their battle mode. They become kind of pointy, sticky, and they start to adhere together. Along with other coagulation factors and red blood cells, they start to form that clot. Then the thing that happens is this beautiful fibrin mesh starts to form, this nice blanket that envelops and holds everything together. That's a typical process of clotting. Now, TXA is an anti-fibrinolytic. So the normal process of fibrinolysis is that we have plasminogen activators from the injured blood vessel. They convert plasminogen to plasmin. Some of those precursor activators are TPA or UPA, but plasminogen normally binds to fibrin, then becomes activated, and plasmin then essentially works to break down that blood clot. That is the process of fibrinolysis. It's breaking down the clot. Essentially what TXA does is TXA inhibits plasmin. So TXA binds into that binding site. This is a synthetic lysine analog. So it binds into this binding site, essentially blocks the binding of fibrin, so you don't go to the active form of plasmin. So essentially you're stabilizing the clot. You're preventing clot breakdown. Now here's a couple of pictures of an electron micrograph of intact fibrin clot. You can see that nice, beautiful kind of mesh holding everything together. After it's exposed to fibrin, the clot then starts to essentially break apart and pull apart and eventually will dissolve. One of the things that is pretty evident in the TXA literature is that it has been shown to reduce surgical bleeding. There is a lot of literature, especially in the realm of cardiothoracic surgery, in orthopedic surgery, and they found that TXA basically in these surgical patients was shown to reduce the need for transfusion by as much as a third. Some of the things that make it promising for the pre-hospital environment is that TXA is very easy to dose, it's easy to administer, it's easy to store. When you look at the dosing, now this dosing is actually the dosing from the CRASH-2 trial. TXA was given in the CRASH-2 trial as 1 gram over 10 minutes, essentially as a loading dose, and then it was followed by essentially a drip of 1 gram and 100 cc's of normal saline over 8 hours. It mixes with just about anything. The things that it doesn't mix well with is it doesn't mix well with factor 7A, doesn't mix well with blood, and it doesn't mix well with penicillin. But other than that, you can pretty much throw it in anything and it'll work. So TXA is pretty easy to use, especially in the pre-hospital environment. And so this was the dosing from the CRASH-2 trial.
Systolic 100. Systolic 90. Get me blood. A clot stabilizer given within 3 hours of injury reduces the risk of bleeding to death by 30%. Check out the CRASH-2 trial.
So let's do that. Let's check out the CRASH-2 trial. We're going to kind of go through a lot of the trial because it's been the big trial that kind of put TXA on most people's radar. We're going to go through a lot of the study design. We'll look at a lot of their outcomes, and then we're going to throw in some other trials to take a look at the use of TXA, possibly for bleeding trauma patients. So the CRASH-2 trial, essentially the collaborators got together, and when they started looking at doing the study, they said, well, what do we know about TXA and some of these other clot stabilizers? What could we potentially use or choose? They looked at things like aprotein. They looked at things like amicar or aminocaproic acid, things that stabilize the clot. They ultimately chose TXA as their clot stabilizer. TXA has been demonstrated to reduce clot breakdown, and in comparison to aminocaproic acid, it's actually shown to be probably about 8 times more effective. TXA reduces bleeding in surgery. They said, well, many trauma patients die from bleeding. Let's see if TXA saves life in bleeding trauma patients. And so then they started the study. Patient enrollment was a big study. They had 20,211 patients. This study was done at a total of 274 hospitals in over 40 countries. They started in around 2005. They randomized this, so this was a double-blinded, placebo-controlled trial. They randomized to the treatment group, the TXA group, and the placebo group. They really only had 4 consents withdrawn. And then if you look at those that they obtained baseline data on, there were 10,093 in the TXA group and 10,114 in the placebo group. They had less than 100 total that were lost to follow-up. And so when you looked at the ultimate numbers that they ended up with, they followed up on 10,060 in the TXA group and 10,067, so very well matched in the placebo group. Now, I have all of the slides for you. I have it. You can take it on Jump Drive, or I can Dropbox it to everybody if you want, so that you get copies of all this stuff, and you can look through the studies on your own. I'm not going to spend a ton of time on this, but bottom line, the baseline factors in the study were very well balanced. If you look at gender between male and female, if you look at age distribution, I stared at this data for a long time. The one that kind of caught my eye, look at the gender, male and female. Look at the 1 on there, unknown. Couldn't somebody have lifted up the sheet or something? I don't know. How can we not get that one right? But the baseline factors were very well balanced when you look at it. If you look at the time since the injury an hour, or essentially the time for administration, this becomes really important, and this stimulated follow-up studies when they teased out some of this data. One of the things that becomes very important is the time to administration. So they have that group that was less than 1 hour, the group that's 1 to 3 hours, and greater than 3 hours. They also looked at the type of injury by blunt or penetrating. They also looked at blood pressures. They looked at Glasgow Coma Scale scores. And let's look at what they found. When we start to break down the data, when you look at the causes of death due to bleeding, there turned out to be 489 in the TXA group. There were 574 deaths in the placebo group. So the p-value was statistically significant. It was 0.0077. They looked at cases of thrombosis. This was one of the biggest concerns going in. If you have something that stabilizes clot, you're worried that you're going to have an increased incidence of thrombosis. You're going to have increased DVT, PE, MI, strokes, and it didn't bear out in the study. There was no increased risk of thrombosis. So they had 33 cases in the TXA group, 48 actually in the placebo group, and we'll go through and we'll break this down a little bit further. They looked at organ failure, head injury, and others. And then any cause of death, they had 1,463 in the TXA group, and then they had 1,613 in the placebo group. So here's some more of the stats. I'm going to kind of go, let's take a look here though. This was what became interesting. When you started to look at the time from initial TXA administration and how these folks did, if you look at those that got TXA in less than 1 hour, their p-value was pretty amazing. Now 1 to 3 hours and then greater than 3 hours. So if you look at essentially the risk ratio, anything obviously to the left of 1 favors the treatment, favors the TXA. So these individuals that got TXA in less than an hour or in that 1 to 3 hour window, it seemed very favorable. However, those people that got TXA late at greater than 3 hours had a trend towards doing worse. And so this actually stimulated a follow-up study from the CRASH 2 publishers. This was some more of their data, kind of as a breakdown. They looked again at time to treatment, systolic blood pressure, GCS score, type of injury, and all thus combined. And essentially just about everything is favoring TXA with one major exception, that those folks that receive TXA at greater than 3 hours seem to do worse. The big point that they one of the main points that they made in the article was the fact that there was no increase in thrombosis, and this was one of the things that most people were concerned about. This clot stabilizer was going to actually increase your incidence of DVT, PI, PE, MI, or stroke. If you actually look kind of down the list, the only one that you had an increased risk in the TXA group was pulmonary embolism. You had 72 versus 71 on the placebo, but everything else actually favored TXA, which was kind of surprising. It was done on 4 different continents and actually shown to reduce mortality on each. So ultimately, they concluded that TXA reduces mortality in bleeding trauma patients. It doesn't seem to increase unwanted clotting. It needs to be given early, ideally within that first 3 hours of injury. And the other important thing is it's not expensive. TXA has been out there a long time. You can get it in the United Kingdom for like less than $10 for a gram dose. You can get it in the United States. Dave, you guys are giving it now on the helicopter. What are you paying for it? Do you have any idea? I know we're paying less than $100 for it at our trauma center. But it's relatively inexpensive. When you look at all the other things that we do, I mean, you think about the data that supports TPA for stroke as a core measure. I'm more concerned about some of the data in TPA for stroke than some of this TXA data when you look at the downsides. So ultimately, reduction in all-cause mortality was 14.5% in the TXA group, 16% in the placebo group. Bleeding-related mortality was reduced, again, 4.9% in the TXA and 5.7% in the placebo group. And again, no increase in fatal vascular occlusive events. So TXA is now being used after the trial. It was added to the World Health Organization list of essential medicines, and this was in March of 2011. Military is using it to treat combat casualties, and there's some studies that look at that. TXA is being used in hospitals around the world, and TXA could be and is given in ambulances. And actually, is anybody else I know David is, but anybody else using TXA right now? Are you guys using it in the field or just at your facility?
Just on the helicopter and on the facility.
So you are using it on the helicopter. Great. Well, and we'll have a discussion. Anybody else? I saw another hand come up over here, a couple. You guys are using it? Helicopter? Helicopter? Great. Okay, more than I thought here. Yeah, it is on our approved medication list, and you're also using it on a helicopter? Good. We're starting at the place that I'm at. We actually just got IRB approval for a study. We're starting a pre-hospital study. The other thing that we're working really hard for in California is we're trying to get TXA on the approved list of medications for paramedics. We just had our recent meeting, actually just earlier in September at our MDAC, and the medical directors from across the state thought it looked quite favorable. And so we may have TXA included in the paramedic scope of practice hopefully soon, but you know how those things move. But I'm planning on starting a pre-hospital study on the basis that I'm supervising using TXA here shortly. But I really wanted to get feedback from you guys on what your thoughts were. I've got a couple of little summaries here on TXA. I did a webinar with Scott Weingart a couple of months ago, and I kind of abbreviated some of this down, but this was his summary and his opinion on TXA after he'd interviewed and spent some time talking to one of the principal investigators, Tim Coates.
So how do we sum this all up? Tranexamic is cheap. We're talking
$100 a gram in the United States, at least at our hospital. In Great Britain, it seems like it's ridiculously cheap, something like the equivalent of less than $10. And it saves lives. Now, probably the greatest benefit is seen in those who are hypotensive or really sick, but if you only gave it to those patients, according to Dr. Coates, you'd be missing out on a lot of the benefit over a much broader population. His contention, you should be giving it to any patient requiring blood transfusion and trauma. You should get that first gram in, which is over 10 minutes, as soon as possible. When you have the time, start the infusion. If you want to get the exact same situation as they had in the CRASH-2 trial. The MATTERS trial will tell us that intermittent boluses would work as well. I don't see any reason not to be giving this. There was no thrombogenic side effects in the enormous population of the CRASH-2 trial. It's not being done. It probably should be done. Start doing it. Get the trauma folks, the critical care folks, the ED folks, and the hematology folks in a room and parse this out. That's what we're doing right now.
There's a lot more on his website. There's a whole bunch of references on EM-Crit. So if you're not familiar with Scott Weingart, he does a blog that's very well received in the emergency medicine world. There's probably 250,000 downloads a month. But on his blog, he's got a lot of other information, a lot of the other studies, aside from just the CRASH-2. Now, follow-up to the CRASH-2 study, when they started looking at all of the different subgroups, and they looked at time to administration is such an important factor, they published a another article that was published from the CRASH-2 collaborators that was the importance of early TXA, and they wanted to talk about how important it was to do it in the first hour or ideally in the first 3 hours. And so this was a little excerpt from Ian Roberts. He was one of the principals on CRASH-2, and this was a brief little excerpt that I edited down from The Lancet.
I'm Ian Roberts, and I'm the clinical coordinator of the CRASH-2 trials at the London School of Hygiene and Tropical Medicine.
Many thanks indeed for talking to The Lancet. If a year ago we thought within 8 hours was a reasonable catch or relevant time frame, but now we're saying within 3 hours, there's an implication, isn't it, that quite often people will need to be given tranexamic acid outside the hospital setting. So is that going to alter trauma protocols, do you think?
I think it will. The knowledge that this is a time-critical intervention will actually push the administration of tranexamic acid as early as possible. In countries where they've got well-developed pre-hospital care systems, then I think it's likely to appear in that setting. Patients will be picked up from the scene and maybe, treated with tranexamic acid in the ambulance or as soon as they arrive in hospital. Most of the effect of tranexamic acid on all-cause mortality was from death due to bleeding. That's what you would expect given the hypothesized mechanism of action of tranexamic acid. So tranexamic acid is an antifibrinolytic agent and it reduces clot breakdown. It supports the coagulation system by strengthening the clots that the patient's forming. Because of its mechanism, most of the effect you'd expect on death due to bleeding. And so it became reasonable to see how did the effect of tranexamic acid on death due to bleeding, which is the clear signal of benefit, how did that vary by time to treatment? And we found remarkably strong evidence that the effect of the treatment varied by time to treatment, such that early treatment was far and away more effective than late treatment. The importance of this second publication is to emphasize that early treatment is absolutely critical. Ideally, treatment in the first hour, which patients who are treated in the first hour, there's more than a 30% reduction in mortality due to bleeding compared to placebo. It's a time-dependent treatment effect, and that's the main conclusion of this second paper.
So that was one of the other points that I also think that makes TXA something that potentially is very favorable for us in the field. Now let's take a look at a little bit more of the literature. Some of the other studies that are out there, there was the MATTERS study, which is the military application of tranexamic acid in trauma and emergency resuscitation. In the MATTERS study, it was retrospective. It was an observational study. It was essentially at one facility in Afghanistan. But they looked at TXA versus no TXA in combat casualties receiving greater than a unit of packed red blood cells. They looked at 896 consecutive patients. 293 had received TXA. they found that the TXA group had lower unadjusted mortality, 17.4 versus 23.9, and there seemed to be benefit for those that received massive transfusion, 14.4% versus 28.1%. So TXA was noted to be independently associated with higher survival. A couple of the other ones, I'm going to throw some of these out. I'm just going to throw out some of the highlights, and then I'll let you kind of go through them on your own, and we're going to have a little discussion, and we're going to get Dr. Davis up to kind of break some of this down a little bit more. There was another study published. It was essentially a Cochrane database review. It was British Medical Journal in 2012, Kerr et al. It was 129 trials that they looked at. So they looked at a total N of 10,488 patients. But essentially what they found was that TXA reduced the probability of receiving blood in elective surgery by as much as a third. And there were fewer groups in the TXA group. Dan had made this little footnote down here about statistical concerns, and I'll come back to that when we get through the rest of these last couple of slides. What about TXA? If it stabilizes the clot, would it be helpful or beneficial in traumatic brain injury? So some of these studies seem to suggest that, but they weren't principally looking at TXA in traumatic brain injury. So we don't have a lot of great data yet, but it's coming. So this was TXA for patients with traumatic brain injury, randomized, double-blinded, placebo-controlled trial. They essentially enrolled 238 patients that were older than 16 years of age. They had moderate to severe traumatic brain injury, GCS of about 4 to 12. And these individuals had essentially a CT scan within the first 8 hours of injury. And then what they would do is they would go back and then they would do follow-up. Now, the folks that were enrolled got a single dose of 2 grams of TXA in addition to all other standard treatments. The primary outcomes that they were looking at were progressive intracranial hemorrhage, which was defined as intracranial hemorrhage seen on the second CT scan that wasn't seen on the first CT scan, or hemorrhage that had increased by greater than 25%. So if you saw it on the first scan, if it was greater than 25% on the second scan, that was also one of the other outcome measures that they looked at. So the difference when they broke it down, if you look at progressive intracranial hemorrhage was present in 21 of 120 patients allocated to the TXA group, and in 32 of the 118 patients allocated to the placebo group. The difference ultimately was not statistically significant, but it seemed to favor the TXA group. So that's stimulating some other research, and actually, and Dan will be able to talk more about this here in a little bit, it looks like the ROC group is going to do a trial of TXA for traumatic brain injury. And actually, it's interesting, I was kind of searching around doing a lit search to try to see who else is doing stuff currently. And right now, let me cue this video. The University of Cincinnati, starting this year in June, I'll speed up a little bit here. So University of Cincinnati, just starting this year in June, is also doing a study. And it looks like the study design is identical to what ROC is going to be doing.
So what's TXA? TXA is a drug that's often prescribed in Europe to women with heavy periods, and it's been found really globally to slow down bleeding in trauma patients. The problem is that it hasn't really been studied well prospectively in the United States, and I think this is a great opportunity to combine a safe drug to a possible patient population that desperately needs something done early in their care. Starting this summer in Cincinnati, we're going to put TXA on our helicopters as a study drug. And the idea is that there's a question whether or not TXA does have an indication for traumatic brain injury, number one, and if it does, what's the right dose? So there are going to be 3 arms in the study, one getting a lot of TXA up front, the second arm getting 1 gram of TXA and then a 2nd gram in the hospital, and then the third arm they're getting placebo. So again, it's a good study to decide whether or not TXA works, but more importantly, if it does work, what's the right dose? And I think that's the big question that people are trying to address in the United States.
So who's adopted TXA into their pre-hospital protocols? Just to name a few that are out there, Royal Flying Doctor Service in Australia is currently using it. Mayo Clinic Hospital helicopters are also using it. The British Columbia Ambulance Service has been using it now for a couple of years, as well as the Southwestern Ambulance Service. And apparently now it looks like we've got at least 5 or 6 of you in here that have been using it for some time, so I'm really curious to hear your experiences. what is still unknown at this point about TXA? A couple of things when you look through the studies. It's important to recognize that we're not 100% sure whether TXA has any impact on trauma outcomes when damage control resuscitation or massive transfusion protocols are utilized. The mechanism by which TXA reduced mortality and trauma in the CRASH-2 trial is not 100% clear. Yes, it stabilizes the clot, but if you look at especially a lot of the cardiac surgery literature, there's probably something else going on with TXA. In some of these studies, they've actually measured inflammatory markers. They've measured things like dimers and interleukin-6, and so they take these inflammatory markers and they look at them in patients that did and did not get TXA, and they actually are finding lower levels of inflammation by virtue of some of these markers. So there may be some other anti-inflammatory effect or something else that we really haven't kind of teased out yet. So there's still something else going on here. Whether fibrinolysis testing should be performed before consideration of the TXA treatment. So when I talk about fibrinolysis treatment, how many of you guys are doing TEGs? Thromboelastography. Anybody doing TEG studies at all? I got 2 hands. Are most of you familiar with the TEG? We don't have it. I work at county. I don't have it yet. I know Dan's got it at UC San Diego. We don't have TEG yet. Essentially, it's looking at how well the body is clotting. It's a point-of-care test. It comes back very quickly, and it gives you additional information above and beyond your PT, PTT, INR about what's going on. It tells you about fibrinolysis. It tells you about platelet effectiveness. So some places are using a TEG now to actually help guide their resuscitation with blood. They can essentially use the TEG and how to use that, help figure out what products they need. Right, and that's one of the big some of the places that had implemented it were concerned about the initial cost and setup, but when they looked at their overuse of certain, whether it be blood or platelets and stuff, and they found out that by using a TEG they didn't in fact necessarily need that, they saved on the other end dramatically, and it justified their cost within a relatively short period of time. So I do think that that's probably the big trend of the future, is using a TEG to try to help guide your blood resuscitation, if you were. But that's something that is still kind of not, kind of virtued by that number of hands out there. We only had 2 people that looked like they were actively using it right now. The other thing that's still of question is what's the optimal dose of TXA and timing in trauma, and then whether other antifibrinolytic agents could be substituted for TXA use in trauma. On Weingart's blog on EMCrit, he does get off into a little discussion on the treatment of some of these antifibrinolytic agents for traumatic brain injury. And actually in their facility, if I remember correctly, they've been using aminocaproic acid. So there's a lot of stuff still going on out there at different facilities. What other questions are still out there? Whether TXA is associated with higher seizure rates in trauma or traumatic brain injury patients. There have been some incidents of increased post-operative seizures in cardiac surgery, but they do tend to use higher doses of TXA that are anywhere from 2 to 10-fold higher than those that were used in the CRASH-2 trial. Some of these seizures, 75 to 80 of them in one study, were associated with increased incidence of neurological complications, delirium and stroke, prolonged recovery, and higher mortality rates. So it's something that we should definitely look at. The proposed mechanism for the seizures is possibly a TXA-mediated inhibition of glycine receptors that are a potential cause of neurotoxicity. There's been a recent FDA label warning that's been added to the TXA. What do we know, though? The things that we do know is that TXA has been associated with a 1.5% reduction in 28-day all-cause mortality in adult trauma patients with signs of bleeding. Those are systolic blood pressure less than 90 and a heart rate greater than 110 in a very large, pragmatic, prospective, randomized, placebo-controlled trial. What is critical is the most modest effect on the overall population. All-cause mortality, though, was significantly reduced from 16 to 14.5%. There's also some good information on the CRASH-2 trial. I don't know if any of you guys use the number needed to treat website, where they kind of go through and they break these down. But the NNT has also got some information on the CRASH-2 trial as well, if you want to refer to that. TXA has shown benefit probably best in that severe shock group and also the group that's given TXA early. TXA had the greatest impact on reduction of death caused by bleeding in that severe shock group. And if you look at their numbers, it was 14.9% versus 18.4%. Early TXA, again, seems to be where it's at, ideally less than 1 hour from injury. 1 to 3 hours after injury also reduced the risk of death by bleeding, but ideally quicker is better. TXA given after 3 hours was associated with increased risk of death caused by bleeding. It didn't have any significant impact on traumatic brain injury outcomes, but the studies that have been out there seem to favor that there may be some benefit there. And so Rock, as well as the University of Cincinnati, are kind of going down that pathway. TXA treatment was not associated with an increased risk of vascular occlusive events. That's all I've got. Thank you very much.